Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Today, I'd like to summarize to you the problem of uterine niche, which is commonly seen nowadays after cesarean delivery. You may be surprised to know that more than 3,500 publications on this topic are present nowadays, and every day you can see a new publication on uterine niche and its impact on the woman's health. So in this short lecture, I would like to summarize to you this topic and to put it in a clinical nutshell. Now, this problem is either underestimated or overestimated by both doctors and patients. It can be underestimated due to lack of awareness or by many doctors and patients that this may be a problem for the woman's health. And also, more than 40% of cases are asymptomatic, so it is commonly underestimated at one side. But it is overestimated by some doctors due to frequency of the cesarean section and frequent visualization of this lesion by ultrasound and frequent use of assisted reproduction, particularly IVF, and frequent surgical options for treating cases of uterine niche. Uterine niche or isthmocele or cesarean section scar defect, diverticulum, cesarean scar syndrome, deficient uterine scar, scar pouch, all when you see this term or other term, they have one meaning, which is a myometrial defect at the site of previous cesarean scar due to defective tissue healing, which is communication with the endometrial cavity with the inner contour of the uterine muscle. The uterine niche may be iatrogenic or almost always iatrogenic, very rarely to be congenital, and almost always follow cesarean delivery, but can occur after some operations like myomectomy. And the European Niche Task Force added to the definitions that not all hypoechogenic shadow seen by ultrasound at the site of cesarean section scar is uterine niche. It should have a depth of at least 2 millimeters to say that it is a uterine niche, in addition to branching and extension towards the anterior uterine wall of this uterine niche. As I told you, almost always follow cesarean section, but rarely has been reported after myomectomy when the myomectomy incision is low near the cervix, like cesarean section scar, hysterotomy scar. So if it is low, this means that the patient may have the criteria of uterine niche, but following myomectomy. And this can be confirmed by the presence of hypervascularity, persistence of abnormal bleeding that disappears after treating these cases, endometrial glands seen in the biopsy, and disappearance of CD 138 positive plasma cells in the endometrial tissue after operative hysteroscopy, as reported in some case reports. But put in mind that it is commonly seen after cesarean delivery. The types or the shapes as seen by ultrasound may be triangular, semilunar, or semicircular, rectangular, circular, doublet, or inclusion cysts. How to diagnose? The diagnosis of uterine niche, as I told you, lack of awareness is the commonest cause of underestimation. So you should have a high index of suspicion, which means that you should put in mind that when you are doing ultrasound for a lady with a previous cesarean section, you should look to the site of cesarean section. Does it show evidence of uterine niche or not? So it requires high index of suspicion. The commonest and easiest method of diagnosis is transvaginal sonography, and you can see hypoechogenic or anechoic area as a scar site, and you should comment on the height of this hypoechogenic area, the width and height and width multiplied and divided on 2 can define the niche area. And in addition, the depth, as mentioned in the definition, it should be at least 2 millimeters. So you will have niche area, width and height, and niche depth. In addition to the residual myometrial thickness, which are MT, all these findings should be put in mind when you are reporting on transvaginal sonography of a cesarean section scar, not only to mention that there is a niche and that's all. No, this is incomplete diagnosis. Why? Because the operation or the decision will rely on your diagnosis. So you should include these 3 items. The niche area, which is width multiplied by the height and divided by 2, the depth should be at least 2 millimeters, and the residual myometrial thickness. All these criteria should be included in the report on uterine niche. And grading depends on the niche area. Grade 1, less than 15 square millimeter. Grade 3, more than 25 square millimeters, and 2 in between. RMT is very important. As I told you, it is a key consideration when choosing the surgical approach. If RMT is less than 3 millimeters, so no rule of hysteroscopic resection or correction, because the wall thickness is very thin, and in such a case, the perforation is expected and bladder injury is expected as well. So if you look to RMT and it is 3 millimeter or more, you can describe for this patient and for yourself, for other doctors, that you can do the operation. If it is more than 3 millimeter, can do it hysteroscopically. If it is less than 3 millimeter, you should do niche repair operation if surgery is indicated. Some additional diagnostic aids include SIS, which is sonohysterography. It is more invasive than transvaginal sonography, and it leads to overestimated diagnosis in some cases, in addition to a spread of infection present in this pouch. 3-dimensional ultrasound is more informative than 2-dimensional. Of course, it is superior for evaluation of the pouch size, width, and niche area, in addition to the RMT. MRI rarely requested, and it shows a high intensity signal of fat saturated T1 weighted images due to accumulation of fluid. Hysteroscopy can see this niche, and in such a case, you can see the crescent view of the internal os. After this crescent view, as I told you in the lecture of safe hysteroscopy, and you have to glide on this crescent of the internal os if the uterus is AVF to go to the endometrial cavity. But in cases of uterine niche, you glide on the crescent of the internal os, but you will find a pouch before reaching the endometrial cavity. This pouch is the uterine niche. So it is a pouch or discontinuity of the anterior uterine wall between the crescent of the internal os and the endometrial cavity. And you may find some retention of blood and dendritic vascular proliferation in this defect. And dendritic vascular proliferation is a characteristic appearance of uterine niche by hysteroscopy. Unfortunately, hysteroscopy is good to see the niche from inside, but it does not give you any idea about RMT. So it has a disadvantage of poor evaluation of the selection of the operation. Can we do hysteroscopy or a niche repair? And this depends on the RMT, which is not feasible by hysteroscopy. So again, transvaginal sonography is the best approach. If you master it, you can find the RMT, you can find the depth, you can find the width, and you can define the area. What are the potential risk factors for uterine niche formation? The potential risk factors can be surgical related or patient related. And this is so important because some patients come to accuse some doctors because they are the cause of this uterine niche and cause of sequelae and complications. Sometimes they go to the court to accuse some doctors. But we have to know that, or to inform the patients that some potential risk factors are related to the operation. This is true, but some other factors related to you as a patient, which are independent risk factors, like genetic predisposition. Some women have genetic predisposition, impaired healing, poor hemostasis, inflammation or adhesion formation. Post-operative infection is common in some patients than others. Gestational diabetes of some women, previous C-section, advanced BMI, longer active labor prior to emergency C-section. All these are contributing factors, independent risk factors. So don't accuse your doctor alone. This is not a defense for the doctors, but this is to get rid of any problem against doctor from the patients in the court or in any case against doctors. At the same time, we have to know that there is no difference between elective and emergency C-section regarding the potential patient-related risk factors. What about surgical related operation? This is related to the doctor. If the doctor is doing the operation low uterine incision, this is the most important surgically related potential risk factors. Low uterine incision means that you are opening in the cervix, which means mucus secreted by cervical glands interferes with myometrial approximation, and this mucus gradually increases, so leads to increased niche size. Also, creation of utrovesical fold by a dissection of the peritoneum over the lower segment can influence the level of uterine incision. Excessive dissection of the bladder is one of the risk factors. If you are doing the operation in the lower uterine segments after cervical dilatation of more than 5 centimeters, prolonged labor more than 5 hours, advanced fetal gestation, this leads to large niche due to thinner or less vascularized myometrium, resulting in inadequate healing. These are the first two surgical related important factors. First of them, I told you the uterine incision, if it is low, using the C-section at the lower uterine segment after cervical dilatation. The closure technique of the doctor, this is another important issue. If you are doing single layer sidual sparing closure technique or single layer, if the muscle edges are thick, non-perpendicular sutures, locking sutures or very tight sutures, suboptimal surgical techniques like inadequate hemostasis, tissue ischemia, devascularization, and excessive tissue manipulations, these are surgeon-related factors. If he is not doing proper surgical technique by doing these improper techniques, he may be the cause of the formation of uterine niche. Adhesions between the anterior the uterus and the anterior abdominal wall can work as a counter force to tract the uterus anteriorly and make this niche more pronounced. The same can occur if the uterus is fixed RVF, and heavy gravid uterus can lead to increased counter force. So adhesions anteriorly make counter traction anteriorly, RVF counter traction on the uterus posteriorly. Both of them can lead to niche formation. So some authors summarize surgical folds as incision through the cervical tissue. As I told you, low cervical incision is the worst cause of the niche formation, adhesion formation, and poor approximation of tissues. And significant risk factors include low uterine incision, because low uterine incision has 6-fold increased risk than high uterine incision for niche formation. Advanced cervical dilatation, low station, non-closure of the peritoneum, and creation of a bladder flap, which is separation of the bladder from the lower uterine segment. All these are contributing factors as mentioned by some authors. What's the evidence that if I incise in the cervical canal, this is the cause, or very low incision, this is the cause of niche. This is the main cause of surgical main cause of niche formation. This can be proved by histologic findings of uterine niche that shows that most of cases show endocervical type mucosa, often cystically dilated, or hybrid endocervical endometrial mucosa of typical of lower uterine segment with atypia and fibroplastic stroma. So the histology mentions that most of the tissues taken from these niche are endocervical or even hybrid endocervical and endometrial. So low uterine or cervical incisions are the most common cause of niche formation. Why the cervical incision is an independent risk factor, surgical risk factor? Because the mucus produced from the cervical tissue accumulates and communicates with each other, forming spaces and retention cysts, and this contributes to the increased niche size. Importantly, to know that some doctors, because they are in a hurry and they are having crowded clinics, so they are doing section in a very short time. So the distance between the stitches is very wide, more than 1 centimeter, and this leads to poor approximation and widening defects, and this can lead to niche formation. So when you are doing section, make the spaces between the stitches as narrow as possible, and the endometrium, if you are doing single and the endometrium is included in the stitch, this is a risk factor for formation of niche. As I told you, adhesions anteriorly, and commonly we see if we are doing laparoscopy for a patient with secondary infertility following cesarean delivery, you will see a central band of adhesion like seen here in this view, and this central band make traction on the lower uterine parts, the isthmus, the cervix, and lower part of the uterus, and this will lead to niche formation. Okay, I saw a case of niche when I am doing ultrasound. I have to ask my patients, do you have any problems in your menstruation or delayed pregnancy and so on? If she is symptomatic and this is incidentally discovered, this means that the patient is asymptomatic and you should not rush to surgical treatment in an asymptomatic patient. But many patients are symptomatic up to 60% of cases, and the frequency of symptoms increase with the increased number of cesarean sections. The symptoms increased with 2 or more cesarean sections than 1 cesarean section, of course. And these symptoms are gynecologic or obstetric symptoms. Gynecologic, it may lead to dysmenorrhea, dyspareunia, chronic pelvic pain, post-menstrual spotting, and this is the commonest presentation of uterine niche and vaginal discharge, in addition to subfertility or infertility in 4 to 19%, and lastly, failed IVF or ICSI. Regarding obstetric symptoms, I have another lecture on obstetric sequelae of uterine niche. This may lead to dehiscence, uterine rupture, ectopic pregnancy, or placenta accreta. What about abnormal uterine bleeding with niche? I told you the most important is post-menstrual spotting, and this is defined as more than 2 days of post-menstrual brownish discharge after the end of menstruation, provided that the menstruation is more than 7 days. But if the menses is less than 7 days, the patient comes with a menses of 3 days and post-menstrual spotting of 2 days. This can be considered normal. So post-menstrual spotting more than 2 days if the menses is exceeding 7 days. The second, and this is etiology, of course, is pouch contains some menstrual blood due to poor contractility, and pouch position, and this leads to retention of the blood, and poor contractility comes due to fibrosis of this site. The second presentation is intermenstrual spotting, which is spotting in between menses, and this is more than 2 days again due to in situ blood collection in this niche and evidenced by free erythrocytes in the scar. The third presentation of abnormal uterine bleeding is prolonged bleeding, and this is due to impaired menstrual drainage, and this can lead to prolonged flow. And actually, prolonged bleeding of this can be added to the Figo-Palm-Cohen nomenclature as of unexplained or not yet specified, which is the last group to be specified. Of course, some patients do not have abnormal uterine bleeding and are asymptomatic. What about infertility? How uterine niche does cause infertility? And this, we have to imagine that this is a site of niche with blood retained inside, infection, chronic endometritis here, so chronic endocervicites, organisms here. How this can lead to infections? The sperms are coming in this side. So the first is the blood and mucus lead to sperm toxicity with defective motility, and the sperm cannot reach the ampulla to fertilize the oocytes. This is number one. Number two, decreased cervical mucus quality here in the cervix. Number three, lead to obstruction of sperm passage by the collection of blood. So mechanical cause due to decreased mucus obstruction and decreased mucus quality, and bacterial cause due to sperm toxicity that kills sperm or at least cause athenospermia. Now the sperm needs to reach to the ampulla. There is retrograde flow of the retained menstrual blood to the fallopian tube, so the sperm cannot reach here. And if fertilization occurs, the fertilized oocyte needs to be implanted into the cavity. It will find endometrium with chronic endometritis and defective implantation, like what occurs in the hydrosalpinx. So these are the basic mechanisms of infertility, sequelae of uterine niche. What about IVF? If we have a patient with uterine niche and we decided to do IVF because we need to bypass this mechanical cause of infertility, so we counsel the patient to do IVF. Actually, it has been noticed that this embryo transfer caster, when comes back from the endometrial cavity after injection, you will find brownish blood discharge on the tip of this caster, which decreases pregnancy rate as found in some studies. Clinical pregnancy rate and live birth rate are significantly lower among patients with cesarean scar defects. So the presence of uterine niche also affects the success of IVF. Don't try to overcome significant niche and symptomatizing niche by doing IVF, because you will face this problem. As I told you in the previous slide, also the endometrium shows endometritis, the retrograde spread of the infection to the fallopian tubes, and septic focus in the uterus. Don't try to do IVF except after good treatment of uterine niche. So we will take a biopsy from this uterine niche, and you will find most of it is endometrial or endocervical or hybrid, or even endocervical alone gland tissues, and some fibrosis, of course, necrosis, adenomyosis, and endometriosis can be seen in this tissue. And don't forget that inflammation is diagnosed in a good number of cases when you see plasma CD138 positive plasma cells, more than 10 plasma cells in 20 high power field. So we diagnose the case as uterine niche by histopathology and by the symptomatology in gynecology or obstetrics, and we have to treat. The patient asks you how to treat this condition. You are my doctor. So actually treatment starts before formation of uterine niche by prevention, preoperative, intraoperative, and postoperative, in addition to surgical treatment. Preoperative prevention, the best preoperative prevention is to avoid cesarean section. So back to normal delivery as fast and safe as possible, because this is one of the late sequelae of liberal use of cesarean delivery, which even done on the patient's request. Also, if cesarean delivery is to be done, infection control is very important, and infection prevention is essential. How to avoid surgical causes? By residency training, standardizing techniques, cost and time saving in clinical packs, documentation, terminology, quality improvement, feedbacks, patients' education. These are preoperative prerequisites to avoid occurrence of niche. Intraoperatively, when you are doing the operation as a doctor, this is a critical situation. You have to put in your mind the sequelae of your suturing, which is uterine niche and rupture uterus and placenta accreta and so on. So you have to be very careful when you are doing this operation. You should minimize adhesion formation, because as I told you, adhesions will make countertraction on the scar and will lead to herniation and pouch formation. More details on minimizing adhesions and how to do a microsurgical cesarean section to preserve fertility and to preserve the uterus and to avoid long-term sequelae of cesarean section is demonstrated in this free book chapter written by myself on microsurgical cesarean section, and you can find it free on the internet. Now, the technical tricks. The most important is to avoid lower uterine incisions. As I told you, this is an independent surgical risk factor. The second important point is to choose uterine closure technique to avoid niche formation, which is double layer, non-looking, running suture, reliable to reduce niche severity. You have to close the peritoneum. And this is an important issue because most of doctors do not close the peritoneum, visceral peritoneum, and leave it because they are in a hurry. And the closure of the peritoneum decreases risk of central bands of adhesions that make traction on the scar. Some doctors or some research inject PRP or some cells inside the scar as a research to avoid adhesion formation. You have to do proper layer approximation, avoid wide-spaced suturing. 2 layers, as I told you, is an important, and you should do 2 layers, continuous running, non-local suture in 2 layers, and you have to take the decidual with you to make the suture like this. The decidual is taken in musculature in 2 layers and serosa at the same time. Injection of PRP and mesenchymal stem cells is tried in some studies. The post-operative prevention after operation, avoid infection. Some papers mention that we can give the patient alpha lipoic acid supplement as a trial to avoid adhesion formation for 6 weeks postpartum as film-coated tablets with 600 milligram dosing orally. These are the pre-operative, intraoperative, and post-operative preventive issues. What about treatment? The first treatment is no treatment. When no treatment, no symptoms, no treatment. Only we are treating patients with secondary infertility, previous scar, ectopic, recurrent miscarriage, abnormal bleeding, or bothersome post-menstrual spotting. So we have to consider, sorry for this, we have to consider symptoms, scar size, defect size, and future conception plan. These are three contributing factors for individualization of the treatment. Now, we will start by medical treatment. Is there a medical treatment for niche? Yes. Some patients who are not desiring fertility, we can give them COCs or progestins as a trial to destroy or make decidualization of the endometrium and to destroy to make these cells are not functioning and no excessive bleeding and size. But this can be joined with antibiotics, as I told you, due to chronic endometritis or other symptomatic treatment. But if the patient is infertile, we cannot give her COCs. We need to give her some medical treatment as she refuses surgical intervention. Particularly, she is planned to IVF. Some studies describe prolonged more than 3 months, ultra-long protocol of pituitary downregulation, and then start induction of ovulation for IVF. But the patient is not planning to do IVF. She needs to get pregnant naturally or spontaneously. So we have to rely for surgical treatment for this symptomatic patient. And surgical treatment can be conventional surgical treatment or endoscopic. And conventional can be abdominal or vaginal, and endoscopic can be hysteroscopic resection or laparoscopic niche repair or robotic surgery. Surgical treatment of niche, as I told you, hysteroscopic resection or ismoplasty. This can be done if the defect is small, less than 3 millimeter width, and also the RMT is less than 3 millimeter, and this is the most important issue. To select hysteroscopy, not all cases are suitable for hysteroscopy. This is a common mistake, that I master hysteroscopy so I can do all cases by hysteroscopy. No, if the RMT is less than 3 millimeters, don't go to hysteroscopy. You have to go to niche repair. The sectoscopic excision of the lower rim of the niche is only if the RMT is more than 3 millimeters. And this can be done by the sectoscopic excision and roller bore coagulation of the bed of the pouch. Niche repair of a big defect or the RMT is less than 3 millimeter, and this can be done by transabdominal or transvaginal approach. The third surgical option for those cases is to do hysterectomy. And this hysterectomy should be included in the counseling if the patient completed our family, approaching menopause, with troublesome bleeding or pain, with failed medical treatment, and surgical option is very risky if the patient has previous cesarean sections, previous laparotomies, and so, and this can lead to unintentional complications. So in such a case, you should counsel the patient to do hysterectomy, and this is the shape of the niche after hysterectomy specimen. Now I'll do hysteroscopy because you told me I can do hysteroscopy of the RMT is more than 3 millimeters. So I made transvaginal sonography, it is 4. Okay, go ahead to do hysteroscopy. But mind you that hysteroscopy is 3 steps, not only 1 step. And this is an important issue because most of the doctors are doing resectoscopic resection of the distal rim only, as it facilitates drainage of the menstrual blood through it, which leads to drainage of the blood, and the lower distal rim only, because if you start to remove the proximal rim, this can lead to cervical incompetence. So doing complete excision of the proximal and distal, this leads to cervical incompetence. Only we cut the distal rim of the niche. And this is step 1. What's step 2 is coagulation of the fragile vessels at the hypervascular base or even entire niche with ball electrode to prevent in situ fluid or blood collection. What's number 3? Number 3 actually is preceding number 1. You should continue bladder safety monitoring by intraoperative ultrasound guidance by one of your assistants, or methylene blue bladder filling, which is done in some studies like his niche trial. So 3 essential steps to have a successful hysteroscopic correction of a niche with RMT more than 3 millimeter, the sectoscopic excision of the distal rim, only distal rim, the coagulation of the bed, and continuous bladder safety by intraoperative continuous ultrasound guidance or injection of methylene blue into the bladder. And this figure shows you that if you are doing excision of the distal and proximal, this can lead to incompetence of the cervix. And this is one of the sequelae of the complications of hysteroscopic correction. But other complications include perforation, bladder injury, and uterine rupture in subsequent pregnancies. So take care that you just excise the distal rim to avoid collection of the retained blood. And these are the figures to describe this. I have a patient with RMT less than 3 millimeters or a big defect. This patient is not suitable for hysteroscopic correction. We have to go to niche repair group. And this niche repair group is actually can be done, as I told you, abdominally or vaginally. And the steps of niche repair is to identify the defect. And I can identify the defect before any operation, because if you don't see the defect properly, you will repair anything. So identification is mandatory by simultaneous hysteroscopy using trans-illumination test by insertion of Heger's dilator, by intracervical Foley's caster, or transvaginal or transrectal ultrasonography. This is number 1, to identify the defect. Number 2, I already see the defect. Now I need to repair. No, you cannot do repair unless you mobilize tissues properly. And mobilization means half of the success of the operation, as mentioned by to me when I was a resident by one of my professors, Professor Hassan Salim, may Allah rest his soul. He always mentioned mobilization is half of success. When you are doing fistula repair, when you are doing perineal tear or niche repair, you should stress on mobilization of tissues to avoid suturing under tension. And suturing, when you are not mobilizing tissues properly, this can lead to failure of the procedure. So mobilization is of utmost importance. So the third step is excision of the fibrotic tissue by trimming of the edges, forces reapproximation in 2 layers, continuous, non-locking, 2 layers. Check integrity of the scar by injection of methylene blue or trans-illumination by hysteroscopy. Round ligament plication in cases of RVF to avoid counter traction on the wall, on the suture, adhesion preventive techniques, and putting some adhesion barriers, and lastly, peritoneal closure. These are the 8 steps of proper niche repair when you are doing it abdominally, laparoscopically, robotically, or vaginally. And exposure of the scar is very important, because previous sections more than 2 to 3 times will have adhesion. And in such a case, bladder should be dissected laterally, right or left, not centrally, to avoid perforation or cutting through the bladder. And more details on exposure of the bladder is found in this lecture in the same channel on non-vascular complications of conventional laparoscopic surgery. It can be done open or laparoscopically or robotically, of course, minimally invasive, and can overcome and treat incidental endometriosis reported in 21% of cases of uterine niche, but they are time consuming. Importantly, to master your technique is don't ignore concomitant hysteroscopy. And hysteroscopy actually is put inside the uterus, so you should have two camera sets to see two screens. And if you are doing laparoscopy with keeping the light of laparoscopy, you can see trans illumination, the light of hysteroscope. But you can sometimes make your light off of the laparoscopy to see the light of the hysteroscopy alone to show the most thin part of the scar and this Halloween sign. Repair, as I told you, double layer full thickness. Robotic is more concise, but more expensive and more time consuming. Open, as I told you, the steps are universal for all techniques, and transvaginal can be done also, and it has been mastered by many teams from Asia, and starts by injection of the vaginal skin by diluted adrenaline to avoid excessive bleeding, vaginal incision, open the vesico-vaginal space, uterine bladder mobilization. As I told you, mobilization is half of success. Cervical dilator to guide you and to see the scar, identification of the defect and trimming of the edges, closure in 2 to 3 layers, and peritoneal closure at the end. This can be used if the niche is located low down. It has advantage of shorter operative time and reduced time of hospitalization as reported in some studies. Now the evidence, which technique I use for niche repair, no evidence. So far, no technique superior to others. But I need to stress here on the point of individualization of the, according to RMT, you can use hysteroscopy, if RMT more than 3 millimeters, less than 3 millimeters, you have the right to do laparoscopy, vaginal or so, according to the your experience, according to availability. But putting in mind that vaginal approach is better to be resorted to low incision near cervix. Contraception is advised after this procedure for 3 to 6 months, as reported in some cases. So in conclusion, I would like to say that uterine niche is frequently diagnosed due to frequent cesarean section or cesarean delivery with lack of standardized techniques. Transvaginal sonography can easily diagnose it. Management plethora requires individualization, and the impact of uterine niche in the subsequent IVF cycles or pregnancy should be included in preoperative counseling of cesarean delivery. Thank you very much.